epiglottitis, all right? Epiglottitis is very rare, all right, because of the introduction of the Haemophilus influenza B or the Hib vaccine. However, this is a life-threatening emergency, okay? Do you think you're going to see a question about this on your test?
No, probably so, if it's life-threatening.
What do you think I'm going to tell you? What do you think when you guys review this, what do you think are the most important things you need to know about this?
Airway. The Hib vaccine.
What especially about airway? What can you not do? Do not open up their mouth, right? Especially do not what? Do not put anything in their mouth, right? Do not put a tongue blade in their mouth, okay? So even if you are visualizing, right, visualizing their epiglottis there, you cannot, even to open, I would even, if you have concern that these kiddos have epiglottitis, right, what can actually happen is you can actually cause spasm of the epiglottis, and that spasm will cause the epiglottis to expand and occlude their entire airway, okay, so you do not want to do that, all right? These kiddos, right, these are often young kids, they look sick. All right, these kids are in the tripod position, right? They're drooling. They can't even swallow their own saliva. All right, these are sick kids. Okay, these are the kids that you see. They have a fever, right? You're taking these kids. You're going right back. You're in the emergency room. You're going to go right back to the primary care provider or wherever you are, right? If you're in a primary care pediatric office, whatever you are, they need to see a provider immediately. Okay, these patients need to have making sure their airway is stable. They oftentimes may actually even be intubated. The provider gets one shot, right? Because we just talked about inducing something in the airway, but they get one shot. If their airway became occluded, what would we need to do? Trach, right? An emergency trach. Okay. Good. All right. Good. These kids need antibiotics, right? We need to get medication on board to help treat this inflammation and this infection. All right, this is kind of the classic picture that you'll see if this is in a lot of textbooks, or if you just Google epiglottitis, it's one of the classic pictures that you will see. All right, that's what they look like though. They can't, their epiglottis is so swollen that they can't control their own secretions. All right, even more so again, they're in that tripod position, they're leaning forward. All right, and it's not like they have pneumonia or things like that. They're not coughing or things like that. They have that epiglottis that's swollen. They cannot control their own secretion. They may have that high fever. They just are sick kids. Okay. Good.
So would like an IV, like a Toradol or something, would that, like an anti-inflammatory, would
they
that?
Probably just use steroids and things.
Steroids, right? Yeah. Okay.
The other thing to know is on these guys, when they want to check it, they'll do a lateral neck x-ray. This is more just as an FYI, but they'll note that they'll have what's called a steeple sign in the way it looks like. You don't need to know that, but that's more of when you become APRNs, you need to know that, okay? But just so you're aware, they need a lateral neck x-ray. What do you think I'm going to put on your test? What? Do not put anything in their mouth. Do not attempt to visualize the throat or put a tongue depressor in their mouth, because that's going to cause that reflex spasm and you're going to occlude their airway. Okay? You already got 2 points on the test, okay? All right? I bet this whole PowerPoint in general, right, if you had to pick out one question, I think there's 7, right? That's 14 points right there. Okay? So, there you go. And then the math, you're already up to what? 20? 18? Okay, so these kids, again, these are not kids that need, you assess them, they need to go right back. These are not kids you send back to the waiting room. These are not kids that you leave alone. These kids, put oxygen on them and bring them back to see a provider. Put an IV in them. All right, we can't allow them to get into more of a position of comfort. Yes, Jen?
How fast does this progress?
It pretty quick. Once they start developing that, when they're getting to this point of drooling and things like that, and really being able to maintain their secretion, they have the fever, right? They really need to be seen and evaluated and make sure that their airway is stable. All right. Again, they may need an emergency trach if needed. All right. So tell me what you need to know about epiglottitis.
Don't open their mouth.
Don't open their mouth, right? Don't put anything in their mouth. Don't open their mouth. What else?
Keep them calm.
Keep them calm. Excellent. Very good. What else?
They might need to be intubated.
Could potentially need to be intubated, right? Really, airway maintenance, right? Okay. What else? Option IV, call a doctor. Excellent job, Sarah. Very good. I love when you get right to the point. Sarah says option IV, call a doctor. Oxygen, IV, and call the doctor. These kids you're going to walk them right back and say, someone needs to see this kid now. Okay?
We're talking about like outpatient. They come like outpatient, or
right? We're talking more outpatient in this situation, yeah. Or if they're at the ER, they're at urgent care, they're at their primary care provider's office. It would be strange if they developed this like inpatient for something else. Like if they were already admitted to the hospital inpatient, right? It would be weird if they would develop this all of a sudden. You know what I mean?
I thought that this was like an emergency kind of situation.
This is, but not every patient. Well, not every patient would know to go to the emergency room, right? Some patients could go to other places. That's all. Okay. All right, you guys okay with this? Yes, Sarah. So it's Haemophilus influenza B is the bacteria. So it used to be Haemophilus influenza B is the most common cause. But now that we have the immunization, we really have seen a sharp decline of this. So the Hib vaccine, right, is very preventative against this. I've never seen this. I had one nurse that I worked with. She worked in the ERs in LA. I don't know if I told you, her name was Dee. She had a lot of energy, and she was like, anyway. But she saw this once, she said, in LA. All right. So you guys didn't read about this, so I'm going to just talk about it a little bit. But this is a little boy, Henry. I love the name Henry. Henry so he was brought to his pediatrician's office for persistent coughing, wheezing, and a large amount of respiratory mucus. His growth does not appear to be proceeding along the expected growth curve. His parents say that he has 8 to 9 bowel movements a day, and they are a lot of straining and gas, and they are large, bulky, and foul-smelling. What do you think is going to be described here? And do you have any ideas of what it might be describing
Well,
here?
the foul smelling sounds kind of like celiac disease, actually.
Okay.
Cystic fibrosis.
This is. Excellent job, Jess. How'd you know?
The mucus.
The mucus. Very good. Okay, good. Good. The excess respiratory mucus? Good. Excellent. So we have the excess respiratory mucus. These are bulky, foul-smelling stools, and we'll talk about why in a second. But this is exactly right. Jess is exactly right. This is cystic fibrosis. Okay? You guys haven't talked about cystic fibrosis yet, correct, in any of your other courses?
Not in nursing.
No. Okay. So I just want to bring it up. Not going to go super in depth, but just so you're aware of a few hallmarks of it. Okay. So one of the most important things to know about this is an autosomal recessive trait or autosomal recessive condition. So what does that mean?
Both parents have to be carriers.
Both parents have to be carriers. Okay. So both parents have to at least have one recessive trait. So if we said it's represented by A, so we would have big A and little a, and each parent would need to be a carrier, okay? Unless they were, so this disease is expressed if they have both. We need to have both little, right? Both recessive traits. So what percentage would it be that 25%, very good, okay? Remember our pungent square, okay? Big A, little a. Okay, so these would be all the potential. These would be all the potential genetic combinations that a baby born to parents that are big A, little a could have, 2 big A, little a. So this would be 25% chance that a baby would have that. So I don't know if you remember, but for maternity screenings, we talked about this, but every mother is going to be screened for cystic fibrosis. Okay, I don't know if every mother is, but if there were any concerns, the mother could be screened for cystic fibrosis. And if the mother was negative, there's no need to go further, right? If the mother does not carry any trait, there's no need to go further. However, if they didn't, then they can test the father to see what their genetics were as well. Okay. One of the things to know is that one of the signs of cystic fibrosis in the fetus is that they can actually have an ileus, a meconium ileus that can be seen on ultrasound. Okay, I actually honestly went through this with my baby. They thought that she had a meconium ileus, and all they did was they checked to make sure I didn't have cystic fibrosis, and then she's fine. But anyhow, so pardon? It's called a meconium ileus. So meconium ileus just means a blockage, like a meconium, so the stool is just stuck in ileus, right? All right. So you can see here a lot of the glands that are going to be involved. All right. So we have our digestive enzymes, our sweat, okay, our lungs we're going to talk about, and then a lot with our pancreas and our intestines and things. All right. What is going to be something else that you might notice when you kiss this baby? Not so sweet, but salty, right? So this is actually an error in chloride transport. But because chloride goes with what? Sodium, right? So they get that salty taste to them. Okay, very good. This is going to be more common in Caucasians. You can see that here. Okay. I don't know about you guys, but this disease has come a long way. I feel like, has anyone known anyone with this disease?
Yeah.
Yeah. So I don't know. I'm feeling old every day that goes by. But when I was growing up, I feel like this disease, there wasn't people often, even in doing a little research as preparing for this lecture, people often lived like to their 30s or 40s or things like that. People are living much longer now. And one of the big reasons is because they developed medications that are able to be modulators of this CFTR gene. And the CFTR gene is what's causing the problems here. Okay? Because that is what's causing, in this situation, if it's not working correctly, dysregulation of the movement of fluoride in and out of cells. Yes?
Is this the one that they can't be, like, if there's two people in cystic fibrosis, they can't be within a certain range of each other?
No. They can be in a range of each other.
Thought they could be.
Yeah, I know what you're talking about. What's that movie?
There's a movie.
I mean, they're definitely at they're definitely at more risk of infection, but
they were supposed to be apart and they loved each other.
Yeah, there's a movie. Yeah.
they can. They're at risk for more infection and things like that, so you have to worry about that. But as long as they were healthy, there's no reason why two people with cystic fibrosis couldn't be near each other.
Cystic fibrosis people cannot be in the same space as each other. Why? This is people with CF infection.
Right. I feel like it's true that cystic fibrosis patients can get infections, but
Yeah, it says it's essential that they be kept at a minimum of 6 feet apart from each other.
but then I feel like they need to be kept at 6 feet apart from any human in general.
Yeah. Yeah.
Yeah. I just feel like there's nothing that they are going to do by interacting with each other that wouldn't be a risk for them in interacting with anyone else. But anyhow, all right. So one of the big things that happens as a result of this, because of this abnormality in our chloride transport, is we end up getting more sticky, thick mucus production. Okay. And that sticky, thick mucus production is actually going to block passageways like different airways and our pancreatic ducts and things like that. Mm-hmm. And as a result of that, when we have that thick, we're going to be more prone to be a medium for bacterial growth and viral growth and things like that. So they're going to become more at risk for infection. Okay? All right. As I said, all right, so this is going to be that CFTR protein, okay? It's an autosomal recessive disorder. And really a result of this, okay, with too much salt and not enough water, we get this sticky mucus, all right? And this primarily affects our respiratory systems and our digestive systems. Okay. So one of the tests that they can do is called the sweat test. Okay, so the sweat test, and that's when they get that salty taste when you kiss them, okay? But it is a true test that they can actually do. The reason that when they have that buildup of mucus, that's why we're going to get more of that chronic cough and things like that, all right? And then also we're going to have this obstruction in their pancreatic ducts, so that's when we're going to affect our pancreatic enzymes and even in our full digestion, insulin, things like that, okay? All right. So the big piece here is our pancreas becomes infected, other digestive enzymes become affected, and then our respiratory, that big, thick mucus here. Oftentimes these patients, is that my next slide? No. I'll get there in a second. But here we can see, so as I said, this is going to be this has a big effect on our pancreas, all right? So we're having an inability in actually breaking down fat, absorbing that we talked about our fat-soluble vitamins, okay? And that's why, because we're not breaking it down and things like that, we get more of these fatty, foul-smelling bowel movements, okay? We can't break down these proteins. this, to be completely honest with you, of what I want you to know, like this is going a little bit further, like really I want you to know cystic fibrosis as an autosomal recessive disorder. It's the CFTR gene mutation that's affecting our chloride transport. We're going to get that salty taste to our skin, and we're going to have this thick mucus production that's going to primarily affect our respiratory system as well as our digestive system, okay? So those, yes, dear.
Sorry. That protein you said it affects.
Which protein?
The
CFTR?
Yes.
So that's going to affect, affects our chloride transport.
Thank you.
Okay. Like this is going a little bit further. Like really I want you to know it does affect our pancreas. It affects our pancreas in these following ways, but it goes a little bit too soon. All right. Again, as I shared with you earlier, so we can screen both parents, okay? After we screen them, if we wanted to find out, if the parents wanted to find out in utero whether or not the baby had cystic fibrosis, they could do it, amniocentesis, okay, or the chronic villi screening, all right. And they also, so they're going to do a sweat test, okay, that's another way they can determine, and then also this trypsinogen test, okay, and that would be what would lead to the sweat test. The sweat test is kind of the conclusive test if they had cystic fibrosis. Okay, so this piece here, again, I'm not want to hold you to this, I just want to talk about this. So what these kids are often treated with, so we have bronchodilators, we would obviously imagine that. We're going to have mucolytics, so medications that are going to help break down that mucus and things like that. So these are going to be big in the treatment. Even just saline is often used. And then these are the new medications, all right? So these are the medications that have really helped for these patients to live longer, these CFTR modulators, okay? By no means do you need to memorize the slide, you need to know anything, just knowing the principles of it is fine. I'm not going to ask you about these medications, okay? Especially not these CFT modulators here. They could take ibuprofen, yeah. And then also digestive drugs. So these patients are going to need actual pancreatic enzymes and things like that. Even, this is similar to the patient these are similar in terms of patients that also are going to need to take like pancreatic enzymes and things like that before meals, okay, in that same way. All right, so we can see here, they're often going to develop infections and need antibiotics. These guys are often also going to get like a chest, okay, that chest physiotherapy, so when they wear the vest and it helps break up all that mucus and move it along, that's going to be a common respiratory treatment for patients who have cystic fibrosis, okay? And again, it was pretty neat. I didn't include it here, but if we look at a chart, just as they've developed these medications, especially the CFT modulators, just again, their life expectancy over time has increased, which is great. Okay.
What is the usual or average age of diagnosis?
I mean, I think it depends. Like,
you can diagnose them when they're babies.
It could be at birth, right?
And some people might not find out till they're pregnant.
Sweat test, yeah. Yeah. They could definitely get diagnosed, infancy and things like that. If they see the meconium ileus on ultrasound and things, then that definitely is a prompting in order to do more testing and things like that, especially after if they tested parents and things. Is she okay?
Oh yeah, she's fine.
Okay.
My husband and I both have the gene.
Oh, you do? Okay.
Yeah, so when we knew going into it,
That
we
she
had
had
to
to.
get tests and stuff,
Yeah.
they watched her. They still watch her just in case, but
Yeah.
she was fine with the sweat test.
Yeah. Oh, nice. That's good.
Wow.
Okay. And you can see here just the airway clearance technique. So this is more cough puffing, and then this is with the actual wearing the vest and things like that, or more percussion to help move along there. Okay. We've talked about this, all right. We've talked about all of these pieces here, so I'm gonna kind of leave that if you guys are okay. All right. And I'm gonna kind of leave this as well, okay? So I really kind of told you what I wanted you to know, all right? This is going a little bit farther. I really was focused more on what it is, how it is passed down, what are the symptoms of it, and then how you would test for it. This is getting more into as they progress into adulthood and things like that. All right. You guys want to do a couple questions? Okay. So parents of a child with cystic fibrosis ask the nurse about genetic implications of the disorder. Which statement made by the nurse expresses accurately the genetic implication? Everybody agree with A? So if both parents have to be carriers of the genes, this is not autosomal dominant, it is what?
Recessive.
Recessive. Is it primarily found in non-Caucasian population groups?
Nope.
No Caucasian. And is there a 50% chance that siblings are also affected?
No.
No. What would be their chance? 25.
Mhm.
I guess A. That's the earliest.
I have to. Yeah.
You have the. Oh yeah.
Good. Good. Because it says earliest, right? Because it says what is the earliest recognizable sign, meconium ileus is correct. Okay? These are both also correct, right? But those wouldn't be your earliest sign. Okay? You guys okay there? So the meconium ileus would be the first recognizable sign. All right. What about this? Which test, if it was in a toddler, which test would you use? The sweat test, right? Good job. All right. You guys feel okay with that? Okay, feel okay with pediatrics in general? Yes, ma'am.
Just curious, the sweat test, I know this sounds stupid, but do they actually take the sweat and send it to a lab, or does the mom just like...
They put like a band on them, and yeah, they have to sweat.
Okay.
Like you have to button them up, and yeah, they send it out, and they test it.
Yeah.
Did you make her sweat?
I just had this image of the doctor looking at me.
I mean,
Oh,
she
geez.
Oh, she was little?
Yeah.
Yeah, so, and they put like just a little band on her, and you just gotta bundle them up. Yeah, it was scary, because we didn't do like, the invasive testing.
I actually know someone who they're both positive for cystic fibrosis, and it's that they're gonna freeze. Well, the doctor's gonna look through all her eggs and actually choose one that isn't a carrier. But you didn't. Okay.
Yeah.
Which is nice that you didn't. She came out fine. Like that's a nice story for people who like, you know.
Growing up, we had a family friend, and they had a daughter who was born with cystic fibrosis, and then they wanted to have another child, and they kept trying to retrieve her eggs. I forget the full story, but they were retrieving her eggs, and every time they were still affected, or I forget the full story, but basically they were unable to ever have another. They were never able to have another baby because I thought it was they actually retrieved her eggs and. But they would be, I don't know, somehow they weren't unable to have another baby without them being affected with cystic fibrosis.
Oh, does that mean all of the eggs probably?
But she was autosomal, she was heterozygous, so she had one big A, one little A, if that's what it was.
Oh, okay.
I'm not sure why, I'm not sure what happened that they couldn't, maybe each one that they made as they fertilized it ended up being positive for cystic fibrosis. I'm not sure how, I don't remember the full story, but anyway, that's what I remember. All right, so now we're going to talk a little bit about the emergency and trauma nursing. And as I walked in today, I heard Sarah, not to tell you out there, but I heard Sarah talking about a recent ER experience. Okay, pardon? They don't touch the patient. Was that just the nurse you were with?
Both of them didn't reevaluate. It's not trauma. They were more concerned about getting all their breathing checks done.
Oh, okay.
So they don't get dinged.
Oh.
And then going by what Ian last said for their medical assessments.
Yeah, that's concerning. So they were not putting an accurate assessment?
What did you find? And then they'll just do that.
Yeah. How about anybody else? What kind of experience how many people in here have been in the emergency room for clinical?
Well, I worked there for 2 years.
Oh, awesome. So what have your experiences been like?
Crazy.
Chaotic.
Okay, so chaotic, crazy, good. What else?
I didn't realize there was like two different sides. So there was like the fast track and then the actual.
Yeah.
Okay, good. Good. So we typically have a fast track and then the main ER. What else?
Freedom. You don't have to worry about like things getting on the floor or arranging tubes and stuff, so you can do your own thing. And my experience was different from Sarah's because they did do like assessment, very focused and like quick. Both like nurses and providers, they were doing like assessments and they were going. You know?
Yeah. Good.
You have to be
Good.
prepared for everything.
Good. You have to be prepared for everything, right? You don't know what's coming. You have to be on your toes.
You can need to, like, if there's no chest tubes, then you have to run into clean utility room. That happened before. We had to, like, someone needed chest tubes, a trauma patient, and everything wasn't stocked properly. So it's all about preparation because you never know what's coming in.
Perfect. Good job. Excellent. Very good. So there's violence, right? So safety is a bigger issue sometimes in the ER as opposed to other areas. Very good. What other experiences have you had?
Teamwork.
Teamwork. Excellent. Do you feel like it's different in the ER than other places? How so?
You have no choice.
True.
Someone's like dying. Everyone just.
It's true.
It's really
My
about
thing
sleeping.
is that like in the ER, the patient's definitely your number one priority.
Yeah.
So it seems that everybody like really focus on that, and they help no matter what because they have no options.
And the
So
providers are right there,
yeah.
which we know,
Right.
if that's the
Right.
case, I think this will
Right.
happen.
I will tell you that one of my biggest pros of being an ER nurse was having access to a provider, like without having to call anyone, page anyone, anything else. Like they were always right there, and that was really helpful. I really enjoyed that. Anybody else have any other feelings? I think you guys hit a lot of really, really, really good words here. You talked about collaboration. You talked about teamwork. How did you notice was communication? Was there good communication?
So we had a situation where I got the feeling that working in the ER was like the place in the hospital where you would be more in danger of not doing something wrong, but being exposed to do something wrong. In the meaning that, like, one of the nurses, like, the patient, like, needed, like, a transfusion, and then he verbalized, he consent, everything with the provider, but it shift change, and then, well, long story short, the patient did not sign the consent, although he had verbalized that. The provider, it was like a resident, so the provider that was supervising the resident did not want to come back, so there was a mess. So I got the feeling that that's a place where things like that might happen, and it's more dangerous for you, like licensed-wise, professional-wise, than other places in the hospital.
Yeah. I agree with you in that aspect. It's definitely more fast-paced. There's definitely room for errors, right? Yes, Jessica?
I feel like I should know that. I kind of looked into it after, but when I was there was a lady with respiratory distress. She's a COPD lady, and she had elevated troponin, and they were kind of like whatever about it, and I was like, so is this maybe like an STEMI? And she's like, no, and I was very confused. So I looked into it after. I feel like I should know this because but like I don't know. I saw that maybe it's not necessarily indicative of NMI, but I kind of thought it was.
So maybe she didn't have the EKG changes to go along with it.
Or could it still be an NSTEMI?
I mean, it could have been like an old, like she could have, you know what I mean?
Old.
I think is it kidney damage?
Other reasons to have elevated troponin.
Like kidney damage. I think like severe kidney damage, if I recall.
Are you thinking like CKMB?
I'm trying to think. We were just talking about this at clinical, and
C kinase.
Creatine kinase.
Yeah.
Something else.
That's a tissue death somewhere.
Yeah, CKMB is more specific, like to the cardiac muscle.
Yeah.
But I mean, it could be there another underlying. Oftentimes, if the troponin may be elevated, but does the troponin match the EKG and that type of thing? I mean, it's definitely, and then the ER definitely more. You need critical thinking, but you also, again, like you can pick up on things, but you have a provider there who's also interpreting things pretty rapidly.
That's probably what it was.
Yeah.
Not that she didn't know anything.
Yeah.
Yeah, because I liked her.
Yeah.
But maybe it's just that, like, sometimes I think you don't have to think as much.
In the ER? I mean, I will say, like, in the ER, because I was so, and not to say this doesn't happen in other places, but I was so busy with other things sometimes, like I wouldn't get to my labs until like the patient was going to be discharged, and they would be like, okay, like they're ready to go, and I'd be like, what? I didn't even like check your labs or anything. But anyhow, but you guys did a really good job. Yes, ma'am.
I just remembered. They stuck me with this was at Charlotte. They stuck me with this girl, and this girl was like a miracle of multitasking. And she just moved. It's kind of like almost like dancing.
Yeah.
Right? So like she like shows me the computer screen and is like, so I have this one, this one, this one, this one. This is where you have to pick out like prioritization, blah blah blah. So this one, which one do you think I need to get to first? And I'm like, oh, I don't know what I'm doing. And then she's like, this one. So then we go to the med room, and like I saw this girl take blood from a patient, just like she had all these different tubes, and she's like in less than, I don't know, 45 seconds.
Yeah. I definitely feel like, and you might see this as well, like I feel like personally, and this is not, I mean, I am being a little stereotypical maybe, but I feel like there's definitely different personalities in the ER. Some, like everywhere has different personalities, but sometimes there's a lot of times nurses are very task oriented. They like to be on the move. They like to be quick. I actually, to be honest with you, feel like I did not fit an ER nurse stereotype. I was, I liked seeing the quickness, and I liked, the patient transfer and things like that. But part of me also, it was quick. You don't often get that slow down kind of reflective type piece. But anyhow, in what you describe, a lot of, I feel like nurses, and this can go on any floor, I'm not being stereotypical, but what I saw, we could have a lot of nurses that were, again, they were very quick, they were doing things, they were doing their tasks, they were going back and like things like that. But anyhow, so, all right. But things that we talk about, and I think you guys brought up each of these. So safety is huge, okay? Often, and safety is big for a number of reasons. You're going to see a lot of patients who are unstable for a variety of reasons. We see more patients in the ER who might be on drugs or, alcohol, drugs, things like that, having more unstable psychiatric symptoms, all right? So exposure to violence or safety exposures can be more common in the ER. And if something traumatic happens, even like things like gangs or things like that, depending on where you work, and if something like someone was hurt or things like that through that type of violence and that was brought to the ER, would that ensue with people coming to the hospital and things? I will say, knock on wood, but I feel like we're usually fairly lucky that doesn't typically happen. Usually that violence stays outside and the patient is cared for, but is that potential there? Is there that potential to bring, on any unit there is that potential, but when it's acute and that's happening right in the moment, what does that look like? So safety is big, okay? Teamwork and collaboration, as I said, I think are huge in the ER. They're huge everywhere. But I feel like personally, in my experience, there's a lot more teamwork and collaboration on a consistent basis, like on an every patient basis in the ER with having the provider right there. You're working with your techs, you're working with your nurses. Everyone is right there constantly working together. And for me, that was a huge plus in the ER. I love that. And communication. So communication is going to be huge anywhere, but again, that's going to be huge in the ER. Okay? All right. So a few things here. So an ER has a commitment that any patient who presents, they are obligated to provide care. They can't turn patients away. Okay? That's different from like an urgent care center even. An urgent care center, if they're able to close is what I'm saying. But if they even run out of time slots, right, they're able to say, I'm sorry, we're no longer able to see you. You have to go somewhere else. Where the ER, right, just continually, they can't turn an obligation to care. Yes.
And they can't turn you away from visitors, or you can't.
Correct. They can't turn. So we're going to talk about that in a second. But they can't turn you away for lack of payment, right? You're exactly right. Okay. The ER, I will just say, and your book talks about this a little bit too. I just feel like the ER, especially as nurses and providers, they kind of have everything under their belt, right? They can be caring for an oncology patient. They can be caring for an ortho patient. They can be caring for a GI patient. They can be caring for a patient with an MI. At the same time, they could be caring for a patient that maybe just underwent some type of chemical exposure. So the knowledge and the treatment that they provide is very, very wide and vast, okay? It's kind of like, do you like to know a little bit about a lot, or do you want to know a lot about a little? It's kind of, I feel like, in the ER, it's like, I feel like knowing a little bit about a lot as opposed to being a specialist in one area. But I will say, the providers, I feel, are often doing a lot of constantly consulting other disciplines to get that help on those areas that they're not as specialists in. Anyhow, so the one thing that I wanted to talk about here is this idea of a critical access hospital. So a critical access hospital is this idea of these hospitals, especially maybe in our area, it's not as significant, but areas out in the Midwest or really rural areas, hospitals that are able to, there are very few beds. You can see here 25 acute care beds, but they can actually provide emergency care 25 days a week. And you can see in this map here, all right, so these are really tiny hospitals, and you can see, again, look at in Connecticut, we really have no critical access hospitals, okay? But if we get into the Midwest, we really see a lot of these critical access hospitals. So really small, and you can imagine what it would be like to be at one of these hospitals, just the limitation in resources and even staff and things like that that you have available to you, and how challenging that might be. Oftentimes these patients would probably have to be shipped to other facilities. Okay, you guys mentioned a lot of this, but as we said, so there's a lot of turnover, okay? I will also say one of the good things about the ER, I mean this happens on every floor, but sometimes, yes, there's rapid change, but there also can be periods of kind of peace, right? So there may be periods of the day, especially I found when I worked like a 7 to 7 shift, when I got in there, when we were at 6:30, it often started slow. So I might have one patient at 6:30, but by, 10 o'clock, I might have my full 5 patients. So you kind of ebb and flow in that way. But you're always getting changes. It's definitely fast-paced and definitely stimulating, all right? Okay, so what do you guys think? What are the biggest reasons that people come to the emergency room? Pain is a big one. Good. What else? Falls. Good. Trauma. So trauma's the big one, right? Good. Trauma. What else?
Chest pain.
Good. Chest pain is a big one. Good. What else?
Silly things.
Okay, silly things. Like, pardon? Mostly. A lot of silly things. Well, I don't know.
Pregnancy test?
Actually, no.
I know, I
say,
have.
I mean, it definitely can happen, but I would say that is a rarer occasion.
Oh, well, she brought her 14-year-old daughter in for a pregnancy test.
Yeah.
And the nurse was like, that's inappropriate.
Yeah.
She said, we're not testing her.
Yeah. Did she turn her away?
Yeah. It was night shift, so you can get away with that. I don't think that was appropriate for the nurse to put the doctor.
Because even in that, there could be not socioeconomic, but social things happening that maybe they did need more of an evaluation or help with. So maybe, like oftentimes they might say they're there for like abdominal pain, but in the end maybe it was just a pregnancy test. I would say
Which is different, but you can't that can't be your complaint, right?
One time, I mean this was kind of one of the funnier things that I had, but it was a camp nurse sent a patient in, and they sent him in because his hands were turning blue. And they were really worried. His hands were turning blue. He had no respiratory symptoms. He was completely fine, but he had gotten new blue jeans. So he was rubbing his blue jeans. So immediately when he came in, the nurse took an alcohol swab and was like, "You're fine." But that was one of the reasons. A lot of it, and we're going to talk about this in a second. I have a few videos to show you, but a lot of this comes back to like access to care. So patients who don't have good access to care, I would say especially things that we saw, like a lot of patients I saw for like dental emergencies because they didn't have a dentist or things like that. They would have an abscessed tooth. They would need antibiotics and pain management before they could get into a dentist. That was a big one. One time I did have someone who came in because they felt like they burned their hands on a cup of coffee when they were, but they didn't burn their hands, whatever, you know what I mean? Just like silly things. But I would say abdominal pain is a big one. A lot of abdominal pain, a lot of GI symptoms, breathing, chest pain, overall not feeling well, fever, a lot of elderly patients with falls, elderly patients with change in mental status, confusion, whether it's urinary tract infections or other things. Yes, orthopedics is big from falls, sutures.
I know we sent like a patient, like the doctor referred them to go straight to the emergency room if they had any any, how do you say it?
Change in mental status?
And for a geriatric consult. So I didn't realize they do that at the ED.
So they probably just do it at the hospital, but they had acute psychiatric changes or so a lot of psychiatric patients as well for various reasons. They can do like a geriatric or a psychiatric consult and even some hospitals will have like a specific geriatric provider and things. But yeah, a lot of the times, sometimes when you're working in the ER, you can kind of feel like you get dumped on per se, just because a lot of times providers or other people might just say, "Oh, just go to the ER, just go to the ER, just go to the ER." And it depends on the situation. Like sometimes it is a negative use of resources and things like that. It becomes expensive, especially depending on the patient's insurance or things like that. But at the same moment, it's an access to care that everyone gets. So when I worked in Middlesex, one of the things that they implemented was they were having a lot of we had a lot of repeat customers per se, right? Frequent flyers, if you work in that setting, they might say. So one of the things, and the issue with that is just that sometimes that can cause a drain or not a drain, but a strain on the ER, because if they're there for non-emergent reasons and there's all these other patients that need to be cared for, there's resources that are being put on these patients. So they actually developed a team that consisted of social workers and nurses, and even a provider, and they did more outpatient care of these patients. So these were part of the family practice office in the Middlesex community, and then they were able to get these patients being seen by their providers as needed more regularly, as opposed to putting the pressure on the emergency room, and that actually worked out really well.
The fast track help for that situation too? Instead of having them wait there even longer, just
Right.
get to the bed, just
Right.
get them in and out.
So the fast track is a great thing as well. The fast track actually though, so one of the big things, one of the big pushes, and this goes back to patient satisfaction, is emergency wait times. So now if you guys notice, you can always go online for every emergency room and see the wait time at the hospital and assess if you'd want to go in or not. But where was I going with this? Oh, so the hospitals, the providers are trying to decrease the wait time. So one of the things that they were doing at Middlesex was every single patient that came in, if our main hospital was full, they would start them in our fast track. Maybe the nurse there would put an IV in them, and then once a bed opened up in the back, they would put them back there. But it created a little bit of a clog in the fast track. My point was just being the fact that the fast track isn't always utilized in the idea that it should. It started to get modulated a little bit. But fast tracks are great, and they do decompress that. Psychiatric patients also comprise a big portion of the ER at times, depending on the circumstance. Typically, there are psychiatric portions of the ER, but in order for the patient to be put back there, they do have to be assessed by a medical provider, medically cleared, in order to go back to that area. And depending on what's going on, that could take a little while. Okay, so if I asked you what were the most common medications being administered in the ER, what would you say? I know you might have looked up here, but what would you have thought before you looked up here even?
Morphine.
Pain medications, okay, what else?
I would have thought fluids.
What would you say?
Fluids.
Fluids, okay, fluids, good. Anything else that you guys thought of?
O2.
Oxygen, excellent job, very good. Good. What else?
Dual neck treatments.
Okay, albuterol, good. 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 I will say I was asked that question when I first became an ER nurse, and I don't know why I feel silly now. I said Benadryl. I was like, what? I don't know why that still sticks to me. I'm like, allergic reaction? I was like, why would I think that? I mean, allergic reactions, but they're really not as common. But anyhow, so these are a few of the lists of the medications. It was an interesting article that I came across. It was just talking about how a lot of the more common meds administered in the ER there were shortages of. And this was just a list of a few of them that had underwent those shortages. Yes, no?
Every time I go to the hospital for whatever, it feels like they prescribe acetaminophen over ibuprofen more. Mm-hmm. It seems to.
That's honestly just provider preference and things. Okay. I feel like actually personally, I mean, I thought both, to be honest with you. And both have advantages and disadvantages, right? Ibuprofen has the anti-inflammatory effect. If the patient has any liver injury or history of liver concerns or alcohol abuse, we probably want to stay away from acetaminophen. The same goes with kidneys for ibuprofen. It just kind of is preference. All right. So this was this was 2018. So this was the reasons why patients administered to the ER. The darker blue is that they were treated and discharged. The lighter blue was that they were admitted. So you can see injury and poisoning was one of the biggest here. So as you guys shared injury, pardon? I think it's just more injury in general as opposed to poisoning. So circulatory system was a big one. So both, we can see being admitted and then also not being admitted. What else do we have? And then digestive system is here, and then respiratory system. So, but injury is kind of one, as you guys shared and thought of, one of the more common. So, like we said, falls, car accidents, falling, whatever it might be, cuts, lacerations, all those types of things. Okay? I just thought that was interesting.
Poisoning's probably on there because, that would be under, kids getting into his kitchen.
Correct. Yeah, so an injury, very good. So injuries and poisonings and things like that, that's the most common cause of death for under the age of 35. All right. So one of the things things also just to talk about. So a lot of vulnerable populations may utilize the ER for whether appropriate or inappropriate. So there we talk about like the homeless or socioeconomically disadvantaged. We talk about mental health or substance abuse, okay, and even the older adults. You know, honestly, a lot of these facilities even sometimes have these regulations of, you know, patients needs being brought to the ER for like trying to cover themselves for so many things too, that also can sometimes create a negative impact on the ER and things, or even on the patient themselves. So just to bring up that piece, but anyhow, all right. So this I just thought was interesting. So I just want to share with you. I know this time is ticking by, but these were 3 videos, and they just highlight the idea of homelessness in the ER.
There's a guy at Charlotte who's homeless. He's been up like 200 something days.
He's admitted to the floor, right?
To the ED, yeah.
He's been in the ED that long?
Yeah.
I feel like I saw a thing in the news where certain hospitals were accused of like patient dumping. Is that a thing?
Patient.
Like just taking them out on a wheelchair, wheeling them up to the edge of a corner and leaving them there.
So depending on the situation, and we're going to look at these videos. So some states like are saying that you can't are saying you cannot discharge a patient that's homeless without providing them with a plan to have somewhere to go, a facility to go. So they have to have that. Some patients, like in the ER, I will say, we discharge patients all the time, and we didn't check with them. Are you home? Like, you know what I mean? Like, even if you know. They typically provided a shelf, like an address on their demographic sheet, but we weren't verifying that type of thing. So I just want to show this. I just feel like it's interesting, kind of highlights.
But the thing about that is, like, I was actually just reading an article in the paper in the Thornton, Winston area about the homelessness, and like there's no place for them anymore. The shelter's full, the overflow is full, so they're trying to like get money from Ned Lamont for some sort of building in one of the towns to house them for the cold weather, but I mean, you can't release them somewhere if there is nowhere.
Right. But I think that's where that issue in itself of not being homeless causes a lot of them to seek refuge at the ER and things like that for different reasons. Like, well, at least I know I can go here, maybe have something to eat, use the bathroom, like whatever it might be, maybe even take a shower. And then, like I said, in some of these hospital settings, when they're actually giving the mandate now that you need to provide a safe home for them to go to after. But yeah, I feel like all of that community, like even going back to community health, like what Joanna was talking about in a little bit, and it's just sad. Like, what can we do? I remember we actually did a mental health rotation with McCall Foundation 2 years ago. And McCall Foundation owns many homes in Torrington. I don't know if they do in Winston, but in Torrington, and they utilize them to house recovering patients with drug and alcohol issues. And one of the clinicians was telling me, she's like, we could buy every home we wanted, and we would fill all of those beds. She's like, we just can't figure out when do you stop, or do you stop? Like, that was just an interesting thing for her to say. She's like, we could buy as many as we'd want, and we could still fill each of them.
There's just so many empty buildings around town. Well, like, I don't know why they can't utilize at least so they're out of the cold.
Right.
Granted, it may not have heat inside, but it's still warmer than it is outside.
Right.
That's what they do in LA and stuff.
That's something they could do
But
with the Yankee
at least in
Peddler.
LA, it's not
Gotta
cold.
do something with it.
But still, they take old like apartment buildings
And refurnish them.
And
But I think but in Connecticut, I feel like when they do get like those critical lows and things like that, they find like whether it's a church or things like that they're putting people in.
Well,
Yeah,
the Trinity Church has the overflow, but it's full. That's what I was reading the other day.
Yeah. So what is they don't have a plan?
And they can go to the Y, but the Y fills
The
up.
Y is
too.
probably full.
Yeah. Oh
They
yeah.
don't have a-
Yeah.
They're trying to get money
Yeah.
to
make
find
a-
another building.
Yeah. I don't know. It's really hard.
They were doing that with like hotels up in New York,
Yeah.
but they made a new thing where you can't stay there for more than a certain allotted amount of time, and they're just constantly rotating people out.
Yeah.
And they don't know what they're going to do for this winter because it's bad.
Hey, Bob, here's dinner.
Well, maybe just, these are only a couple minutes.
Is it good?
Yeah.
They blame it all on my mental illness or my drug use or my alcohol use, and then I stop my drug use and my alcohol use, then they put me on medication that doesn't work. And like there's like serious side effects where my body's shaking all the time, like my hand hurts all the time.
That was Carlos. He says that he's been experiencing homelessness his entire life, and he currently lives in Cesar Chavez Plaza, and he's what experts in medicine and public policy call a member of the revolving door. So here to talk about what that means and solutions for it in Sacramento is Devin Truvy. Devin, what do we understand the revolving door to be in this context?
Right, so it's a person experiencing homelessness that goes into the ER for care, only unfortunately to have to return to the streets and then back to the ER for continuous care in situations like that. Now, for those repeat patients that come back as many as 4 times in 90 days, only about 1 in 10 have housing, and 39% of the unhoused repeat patients, they have substance use issues. Now, some of the solutions that doctors from UC Davis like would be resources to enroll them in long-term outpatient programs, but they need more, which is why Sacramento Mayor Darrell Steinberg was also a part of the conversation today to address how the new city-county agreement can help.
Navigate them to a core center, a county-run mental health center as opposed to an emergency room, to have the beds to back it up. Then we have a much better chance